This video covers endoscopic ultrasound guided technique of coil and the glue injection of a bronchial artery aneurysm in symptomatic patient. After using the Doppler, you confirm the target lesion. You can appreciate the turbulence of the blood flow. Here the mediastinum aneurysm arising just adjacent to arch of aorta from descending aorta. It measures 3.5 to 3.4 centimeter. Now with the help of 19 gauge FNA needle, I am puncturing the target lesion. Now you can appreciate the needle in target aneurysm. Now I am removing the stylet. A jet of a blood flow is coming into a syringe. I nearly aspirate 1 ml of the blood, confirming it is the artery, vascular artery. Now I am flushing the needle, FNA needle, with 2 ml distilled water in order to prevent the premature clogging of a needle. This patient was symptomatic, and conventional radiological methods were done 2 times but unfortunately failed. Now after flushing the needle thoroughly with the distilled water, you can appreciate the strands, hyperechoic strands, rotating and aneurysm. Now our plan is to put the coil, keeping the diameter of aneurysm into consideration. You can use larger coil with variable coil length that can form the loop diameter of 20 mm. Here I am placing the small coil made of nickel. You can use a platinum based coil also. This was deployed to check everything is fine. However, there is a chance of getting embolized to the distant organs, especially to the lung, heart, and the brain. But we were lucky enough that the coil remained in situ. You can appreciate there is a hyperechoic foci at 6 o'clock and a clot formation. As we know, the coil helps retain the glue at the site of injection, and it helps as a scaffold. It also promotes clot aggregation and reduces the amount of the glue. So here you can see that coil is in situ. Now I am applying the larger coil with which will form the loop diameter of 20 mm. Length is nearly 10 centimeter. So coil technique insertion is the same as we are using in gastric varix. Here we are we insert a lock loop hub. Coil is introduced to FNA needle. You advance the coil into FNA needle, remove the stylet and introducer, reintroduce the stylet to advance the coil, so you can deploy the coil easily. The procedure should be done under guidance and with patience. Here now the coil is being advanced slowly into the target lumen. I'm using the linear echo endoscope at a frequency 7.5 megahertz. Yes, is very helpful to see and target the feeding vessel and target the vessel lumen. Now you can gently advance and you can appreciate same under the floor. It forms 4 to 5 loops of loop diameter 20 mm. As I measured, it may take 4 to 5 coils. Now I am placing third coil. I'm gently advancing the coil with the help of a stylet. So you can appreciate these hyperechoic strands, and same you can see under the floor how beautifully they are looking. Now I am using the pre-mixed lipid oil and isobutyl cyanoacrylate glue. I have used total 3.5 ml of equal concentration of isobutyl cyanoacrylate and lipid oil. You can use octyl 2 cyanoacrylate because we in our part of world availability of octyl 2 cyanoacrylate is difficult. It is available in the market under Dermobron. It helps because of its advantages. Octyl 2 cyanoacrylate blue has 3 to 4 times longer polymerization time. It is less histotoxic and it has a low risks of sequelae, carries especially after injection. I'm using a pre-mixed lipid oil with the 2 reasons. First, it enhances the polymerization time, and second, helps to localize under the fluoro whether the glue has got embolized to distant organs. Now you can appreciate, you gently inject this, and you can see it is forming the hyperechoicity, and you can appreciate same under the fluoroscopy how beautifully it is filling. There's the risk of a needle stick to the target lesion, and risk of a premature catheter plugging as well, but here the procedure is being done, the route is through transesophageal, so esophagus acts as a board, so less fear of needle sticking. You can gently remove the needle and you can place the transducer in the lumen of the esophagus to provide the tamponade so that risk of bleeding is less. Now after removing, I will put the standard Gastro forward view. On the forward view you can see the site of the puncture, it has solidified, there is no blood at all, procedure is very clean. This procedure has been done under moderate sedation, especially under the care of a general anesthesia. Patient was intubated. Thank you for watching this video.